of this conference. I do have to confess that I've pre-recorded this talk quite a few weeks in advance, so I hope that there'll be no groundbreaking research that will be published between now and when the conference actually happens, and I've missed it. But let's get going. So I'll talk to you today about restoring the airflow via the upper airway for mechanically ventilated intensive care patients with a tracheostomy. As you know, when a patient is mechanically ventilated, then usually their tracheostomy tube cuff is inflated, which means that there is no airflow via the patient's upper airway. And therefore, if there's no airflow, then the sensation is altered, taste and smell are altered. There's no ability for the patient to cough up towards their mouth and nose. There's also limited ability to clear secretions. They can't clear anything that's already below the vocal cords. And obviously, there is no voice because all of the airflow goes below the vocal folds. So what do we know about when it comes to respiration and swallow for these mechanically ventilated patients? We know that mechanical ventilation usually initially bypasses the mouth, the nose, the pharynx, and the larynx, and therefore there's this lack of sensory input aside from a big endotracheal tube. We know that these patients are often sedated. We also know that healthy people only swallow about 3 times an hour during sleep, and overall about 900 times a day. Ventilated patients that are sedated, therefore asleep, or even worse, they might be paralyzed, only swallow less than 100 times a day, if that. So there comes disused muscle atrophy, obviously, even from lack of practice and obviously from other factors. We also know that thirst and communication have been reported to be major stress factors for ventilated patients. But we also know that patients can eat and drink whilst they're ventilated and can talk whilst they're ventilated. Obviously not when they've got an endotracheal tube, but once they receive a tracheostomy tube, then by all means, yes. And it's often not happening due to lack of speech pathology, presence in ICU, or lack of speech pathology confidence in working with these patients. Once the patients get extubated, meaning that the endotracheal tube comes out, whether a tracheostomy goes in or not, there is a high prevalence of laryngeal injury post the period of intubation. And Dr. Brodsky, with his colleagues, has found that in their systematic review that dysphonia and pain are present in 3/4 of these patients. Dysphagia is present in nearly half, and then laryngeal dyspnea and stridor a little less than that. There's also a great new paper from Sarah Wallace and Brendan McGrath talking about laryngeal complications after tracheal intubation and tracheostomy. I highly recommend that paper if you haven't had a look. And we also know that due to COVID, the prevalence of laryngotracheal stenosis and all sorts of upper airway damage is much more likely to happen than in patients pre-COVID. And some other things to consider post endotracheal tube or ventilation. We know that the diaphragm starts atrophying post 18 hours of being on mechanical ventilation, so very, very quickly. The quadriceps ultrasound has showed an 18% reduction in muscle mass in just 10 days of lying in an ICU bed. We know that the tongue is 35% weaker, even 48 hours post-extubation in patients where the average duration of intubation lasted nearly 8 days. And we also know that extubated patients with acute respiratory distress syndrome take longer time to achieve laryngeal closure, and they have a shorter duration of upper esophageal sphincter opening. So all of these combined, we still don't know much about pharyngeal and laryngeal muscles, but if the bigger muscles have such a significant reduction in muscle mass, then we can, guess for sure that pharyngeal and laryngeal muscles would not be spared. But by the time a patient gets a tracheostomy in an ICU and is still on the ventilator, usually by that time they have had a period with an endotracheal tube. They have spent at least a week lying in an ICU bed, sometimes 2 weeks, sometimes even more. They have not had their voice for the same duration. They have not had anything to eat or drink for the same duration. They have usually not mobilized out of bed for the same duration. And then there are these ICU environmental factors of, lack of the normal circadian rhythm, all the noise all around them all the time, really confusing the day and night, leading to delirium and other issues that all would have an impact on swallowing as well. We know that respiration and swallowing collaborate heavily, and Bonnie Martin Harris has published around these 4 different patterns of respiration and or swallow breath cycle, essentially. And the most common strategy would be expiration followed by swallow and followed by expiration again. With other patterns less common. But respiration and swallow share a common space, which is the upper airway. Whereas if there's a patient with a tracheostomy tube where the cuff is inflated, then they don't share that common airway. They don't share that common space because airway is essentially below the vocal cords. So therefore, coordination may be slightly different as well. We also know that there's specific diaphragmatic and abdominal muscle activity during the apneic period of the swallow, which promotes expiratory airflow post-swallow. But again, if the cuff is up, we can't be sure that it's actually happening that way. A little bit about subglottic pressure as well. So firstly, what it is the pressure that develops below the vocal folds during the swallow, and it's present thanks to respiratory system recoil. We also know that higher subglottic pressure is higher with bigger tidal volumes. It's always negative on residual volume and often negative with swallows at functional residual capacity. And with total lung capacity in normals, the subglottic pressure ranges between 7 and 11 centimeters of water. And also in non-aspirating tracheostomized patients, it's very similar. But how does it develop? So there are biphasic air pressure recordings likely due to diaphragmatic involvement in swallow. So the diaphragm becomes active prior to swallow onset to maintain the lung volume during swallow for subglottic pressure and also to preserve some air for exhalation post-swallow. And implications for ventilated patients, obviously with a tracheostomy from all of this is if there's no airflow, then there is no pressure. Vocal folds may still close, but there won't be that subglottic pressure under the vocal folds because there is no air movement through there. And studies indirectly looking at subglottic pressures with occluded versus non-occluded tracheostomy tubes have reported that aspiration is either eliminated or reduced. So it is very good to be able to produce that subglottic pressure in terms of when it comes to swallow safety. Observations have also been made that bigger tidal volume protects better from aspiration. And if we look at it, then it really is like a modified supraglottic swallow. And coordination of swallowing and breathing, as I mentioned, can be quite different when the cuff is up and there is no airflow via the upper airway, which also begs the question of patient suitability for cuff up feeding. And lung recoilability is definitely something to consider here too, patients with COPD, for example. And the biggest takeaway from the whole of my talk today is to get in there as soon as possible. As soon as the upper airway is free from tubing, it's free for using, and all of the potential difficulties can be addressed. So even if the endotracheal tube is replaced by a tracheostomy tube, we should start using that upper airway. And we should intervene with a view to avoid further desensitization and deconditioning due to ongoing lack of airflow and inactivity. So if we have the upper airway free, we should start using it. Yes, we have the tracheostomy tube here, but if we leave the cuff inflated, we just keep, we risk further desensitization, as I said, and further deconditioning, because for good motor response, one needs sensory input. So therefore, ideally, rehabilitation of the upper airway should include restoration of airflow via the patient's upper airway. And often periods of restored airflow is therapy because you're you're providing sensory input, and hopefully gaining a better motor response there for the swallow. Obviously, if the patients are in ICU looking like this, then one might say that, oh, what are my priorities here? Yes, of course, our priority is to make sure that this patient survives, but we also have to make sure that this this life afterwards is worth living, and we're not making their condition any worse by just waiting and not doing anything with their upper airway. So laryngeal weaning I've written. I really wanted to say laryngeal rehabilitation, really. Order of laryngeal rehabilitation with the goal to restore upper airway function in my world starts with one-way valve, which is the most natural way for the patient to use their upper airway whilst they're still with a tracheostomy tube and on mechanical ventilation. We recently published an opinion piece wrote an opinion piece for the Journal of Intensive Care Society with my colleagues Sarah and Sue, and that has been accepted to be published. So by the time you're hearing this talk, it may already be published. And the main idea behind that opinion piece is to give guidance on the order of laryngeal rehab with tracheostomized ventilated patients. So I'll give you a bit of an overview of that here today as well. So one-way valve, obviously, as most of you would know, is a lot of people call it a speaking valve. I like to call it a one-way valve because there's much more to it than just speaking. So it is a valve that only opens one way, so it lets the patient inhale via their tracheostomy. But as the patient starts to exhale, all of the air goes around the deflated cuff up through the patient's upper airway. And that's all of the air. Nothing goes back to the tracheostomy, which is why it also is the most natural way, I guess, because the whole exhalation is able to be used via the upper airway, either for communication or for building good subglottic pressure around the vocal cords, or for coughing, etc. But these valves are often not used on the ventilator due to different kinds of myths that are out there. And I was thinking of busting some of these myths here today by talking about research that supports the use of the valves. So first myth, and usually the biggest myth in the ICUs, is that the patient is still on the ventilator, therefore I can't deflate their cuff in order to use a one-way valve, as they will de-recruit their lungs. So I'll tell you about our journey, about in our cardiothoracic ICU in Australia, and it's also my PhD journey as well. So prior to 2012 in that unit, there were no speaking valves used with ventilated patients. It really was a quiet zone for them. And if we talk about, the main concern was that if we deflate the cuff, they'll de-recruit their lungs. So let's talk about lung recruitment a little bit. I'll show you a little video here of alveoli at a cellular level. And you can see that they're like little small balloons. And we want those alveoli to be open for good gas exchange. And we don't want them to collapse after every time we breathe out. So we want them open and staying open. And areas such as these ones in the corner here, where there are no visible balloons, means that the alveoli are collapsed. So they're de-recruited parts of the lung that are not taking part in gas exchange. So we don't want that. We don't want these atelectatic areas or de-recruited areas. And you'll see in the video how by adding positive end expiratory pressure, or PEEP, more of these balloons, more alveoli start to pop open. So here, there, and everywhere, this area still remains de-recruited initially, but by adding more PEEP, you'll see how this area gets recruited also, just like that. So that's the ideal scenario, because lung recruitment has been spoken about for decades and decades, and mechanical ventilation is all about getting the lungs recruited and getting the lungs better again. But from the ventilator, we don't really know how the air is distributed in the lungs. We can see how much goes in, how much comes out, how the patient is doing in general, but not all alveoli are equal, and the air always moves the path of least resistance. So you might get areas in the lungs that are hyperinflated, you might get areas in the lungs that are de-recruited, and you won't know until you have a chest X-ray that shows you what's happening, or a chest CT or an MRI. So they're a bit more informative than just the breath-by-breath ventilator information at the bedside. So lots of studies are looking at recruitment maneuvers to see how to recruit the areas that are de-recruited, like how can we involve these in gas exchange as well. But as soon as we put a one-way valve in line, we can't even see what's coming back from the patient anymore because everything is exhaled via their mouth and nose. So we're essentially left blind, and that's not something that clinicians in ICU like. They like to be in charge, like to be in control, and know exactly what's happening to the patients. So it can sometimes be quite difficult to convince your intensivists to be agreeable to using a one-way valve, which is also why this study was quite important. So as part of equipment for our critical care research group, we had a piece of machinery called electrical impedance tomography, which is a real-time, radiation-free bedside monitoring tool of the patient's lungs, basically. We can see breath by breath how the air goes in and out of the lungs and where the air goes into the lung. So even a lot more information than what the ventilator can give us. And if you look at the picture, it's like a chest X-ray, basically. Left is right, right is left. Upper parts are anterior aspects of the lungs, and bottom parts are posterior aspects of the lung. And how does EIT work? So there is a belt around the patient's chest with 16 electrodes, and electrical current is injected at each of these 16 positions and read at the next electrode pair, creating 208 potentials per image. And image reconstruction is then based on that information. So calculation of single tomograms happens using those 208 potentials. And the resulting tomogram represents changes of bioelectric properties of the tissue, in our case, due to ventilation. We didn't look at perfusion. And the resulting image, comparing it to a CT, is here. And a lot more people would be familiar with a CT image, where you can see that where there's more air entry on the CT, the equivalent EIT image shows you more color. Whereas in the other lung, there's not a lot of air entry. There's also then not a lot of color on the EIT image. We're able to sit like this for much more than an hour. So we had to keep it slightly short. In the study, we also used respiratory inductance plethysmography to monitor the difference between abdominal and chest mobility during breathing, with the theory of, do we get increased abdominal mobility with the use of speaking valve? Because we know that diaphragm weakness develops already 18 hours post mechanical ventilation. So by the time they get a tracheostomy and they're still ventilated, their diaphragm would definitely be reduced in their ability to participate in respiration. So that was hopefully some useful information as well. And the research trolley on the background here, which was thankfully put together by our clinical engineer. And moving on, we had 20 participants, 50% happened to be female. You can see the mean age here. 13 of them were admitted for cardiac surgery, 5 for respiratory failure, including ARDS, and 1 for GI surgery. Most were percutaneous tracheostomies. On average, it took them nearly 5 days after the insertion of tracheostomy tube to start using a one-way valve, and they were then recruited to the study about 2.5 days after first use of the valve. We had 10 patients on the ventilator for the study and 10 patients doing trials off the ventilator, and we recruited them whilst they were on high-flow oxygen via their tracheostomy. 9 of those that we looked at whilst they were using Optiflow actually still needed ventilation, at least overnight, if not even for stints during the day as well. So they were by all means not weaned from the ventilator. And in terms of results, what did we see? The ones underlined with the red line are the significant changes. So up the top, we have baseline. We have first 15 minutes with a speaking valve when they were not talking. Then we have a second 15 minutes with a speaking valve where they were talking. And then last 15 minutes when the speaking valve was taken off and they were put back onto their baseline settings. So respiratory rate dropped significantly during speaking valve use. end tidal CO2 dropped significantly during speaking valve use. And the way we measured it was with a catheter down their tracheostomy, just down past the end, the tip of the tracheostomy tube in their airway, because otherwise, unless you've got transcutaneous CO2 monitoring, you can't look at CO2 whilst the one-way valve is in line. And also end expiratory lung impedance, the information that we got from the EIT machine showed that to the contrary of what was believed, that will de-recruit their lungs, they were actually recruiting their lungs with the speaking valve, and they continued recruiting their lungs even after we've removed the speaking valve. So the speaking valve looked like it was acting like a recruitment maneuver. And in terms of colors on the pictures here, you can see the first column here is with no speaking valve. So end expiration, end inspiration with no speaking valve, and then end expiration, end expiration, inspiration, with speaking valve. So you can see how there's the lungs are just a lot more opened up, and there's a lot more gas exchange happening, or I should say, gas exchange happening with the speaking valve. So we could conclude that in this cohort of critically ill ventilated patients, speaking valves did not cause de-recruitment of the lungs when used in the ventilator weaning period. And often they may even facilitate lung recruitment both during and after speaking valve use. We also saw significantly increased abdominal activity with the speaking valve use, as we predicted. And these data were then published in this article here too. But we know that end expiratory lung volumes increased, but what we didn't know with the initial analysis of the data was that, does this indicate recruitment or in fact hyperinflation in some areas of the lung? And luckily, the company was Draeger, whose EIT equipment we were using. They came out with a new data analysis program, which enabled us to look at where the air went in the lungs as well. And after analysing that data, we could conclude in this article that hyperinflation did not occur with speaking valve use. In fact, the recruitment was sort of quite unison around the lungs. So the lungs were definitely doing better with the speaking valve and after speaking valve use as well. And these data, along with obvious psychological benefits to patients, are certainly encouraging towards safe use of speaking valves in this critical ill cardiothoracic patient population. And often I get asked this question, oh, what about our neuro patients? They're quite different. And my reply to that often is that, yes, they're different because if they're really, severe, let's say, spinal patients, then their primary issue is not normally lung recruitment. Their primary issue is the central control over breathing. And that's quite a different worry. And that's not what this study went to investigate. So we shouldn't be concerned about hyperinflation or lung recruitment in any of the patient populations, because this study was looking at the most unwell patients in that sense. They were all in respiratory failure. So I guess that the lung recruitment concern is certainly answered with this study, despite this set cohort of patients. We also looked at tracheostomy outcomes over these similar years in our ICU. And 2011 was the year where there were no ventilated tracheostomized patients using a speaking valve. And then the study happened during that period with rapid change in I guess what we were doing clinically. So the percentage of speaking valve users amongst tracheostomized patients grew to around 3/4 of the patients that were tracheostomized. And also other significant changes were the number of days from tracheostomy insertion to first use of speaking valve dropped by 3-fold. And also the percentage of speaking valve use on the ventilator increased to 70% from 0. So it was definitely a drastic change in clinical practice. And when we're looking at communication outcomes as well, we're asking short questionnaires on a Likert scale from both patients and nursing staff, and both report significantly greater success with communication when the speaking valve was in situ, obviously, I guess. If we look at those, the graph here, then the top line is when the patients were voiceless. The red mark is patients answering the question about how successful they were with their communication. and blue mark is nursing staff's opinion about the patient's success with communication. And you can see the discrepancy here. The nurses think that, yes, they're not very successful, but the patients are quite okay, whereas the patients themselves felt like they were not successful at all. And I guess that discrepancy may lead to further frustration for the patients, with nursing staff thinking that they understood the patient, walking away, whereas the message actually hadn't been communicated across. And the bottom one is where the patients have their voice back thanks to the speaking valve or one-way valve. And you can see how the ratings then are very, very similar. And this paper, I forgot to mention, will be published in the American Journal of Critical Care soon as well. It was accepted back in February, but just the process is a bit slow. But I just wanted to put this support slide up here, because without the financial support from NHMRC in Australia and the Common Good at our hospital there, I wouldn't have been able to do it. And if it wasn't for the brain support, then I definitely wouldn't have been able to do it. So thanks a lot to all of these people, and just some references to use directly from this study as well. But moving on to myth number 2 is subglottic secretion volumes are too high, therefore can't deflate the cuff. And my reply to this often is that if we don't restore the airflow via the upper airway, then the patient may even be unaware of the secretions pooling. And if they are aware, then they can't do anything about it. Once it's gone beyond the vocal cords, they can't cough it out if there's no airflow. And it's almost like physio saying, let's not get the patient moving yet because they are too weak. We can't stay and wait for spontaneous recovery. We have to start doing something about it. And we also can't expect a good motor response without sensory input. We definitely need to assess and treat under best conditions, meaning as close as possible to normal physiology. And sometimes when you do deflate the cuff and start using a speaking valve, something like that, then sometimes we find out that, yes, we need to address the secretion issue. We need to do something about it. But we definitely can't just wait and see whether it gets better or not. And quite often, if they are still ventilated, then pressure and flow from the ventilator actually help protect the airway. So it's the safest time to start, rather than waiting until they're off the ventilator and then leaving the patient to, fight it out themselves. Why does it not want to play? And reduce the ventilator delivered PEEP by 5. So they're now on PEEP of 3 instead of PEEP of 8 here, and the speaking valve is in line. And same sort of slightly thick fluid is given, and see what's happening with the penetrated material. So every time it enters the airway, it's pushed back out. It comes down towards the airway again, coming down the cords, going past the cords. Once they're pushed out, then the patient is coughing as well. So purely by restoring the airflow, firstly, the airflow from the ventilator keeps pushing the penetrated material out of the airway, but also once aspiration does happen, the patient is actually sensate to it. They can do something about it. They can cough. So if this same patient, we did the same thing, same swallow assessment at the bedside without imaging, then obviously the first one would have been, oh, they're actually quite good. No cough, no nothing. I think they're safe. And with the second one, oh, they're coughing, they must be aspirating. So at the bedside, it would be really difficult to see or to know what's actually happening, which is what we all know about the instrumental assessment, whereas bedside assessment anyway. But just to highlight how the airflow actually makes a difference. And the fact that the patient was coughing was actually a good thing. But under that same myth, there's also a paper from a good colleague of mine, actually in Australia, that was looking at clinical indicators associated with successful tracheostomy cuff deflation. And she was looking whether there is a certain amount of above the cuff secretions that would predict successful cuff deflation. So she did a retrospective review of 113 acutely tracheostomized patients with a subglottic suction tube in situ. And 95% of these patients achieved continuous cuff deflation on the first attempt. And she found that there was a set of 3 clinically driven criteria, and I'll mention one of them. Above the cuff secretions were less than 1 milliliter an hour. But I guess, it's good to have numbers. But again, if you don't do anything about it, then how do you expect these secretions to get better? So in my world, this is an absolutely unnecessary delay of assessment and treatment. We can't just wait for the muscles to improve. We actually have to intervene a lot earlier and start the patient's, use of their upper airway much earlier. Third myth that prevents people from using one-way valves with ventilated patients is increased work of breathing in one-way valves. So they often say, we put it in, the patient had increased work of breathing, couldn't tolerate the valve, they often say, and we took it off. But I would say that it's not the one-way valve that is causing increased work of breathing. And there's a lot of considerations or tips that I'd like to give to you to think about what could be causing the increased work of breathing. Are you sure the upper airway assessment was done properly? Perhaps there's just not enough room for all of the expiration to go via the upper airway. Have you reduced their ventilator-delivered PEEP? Because if the ventilator still delivers the same amount of PEEP that it was before, and now you're forcing the patient to breathe around a deflated cuff, a tracheostomy tube that takes at least 2/3 of their trachea through their upper airway, that's potentially quite edematous, that adds a lot of resistance to breathing out. So their patients end up getting a lot of PEEP, which makes their work of breathing more difficult, obviously. Is the ventilator perhaps auto-triggering breaths? Is the patient managing the vent flow and coordinating their breaths? Is the patient perhaps anxious, or maybe they're excited, maybe they're frustrated, maybe they're angry, maybe patient education wasn't provided sufficiently prior to using the speaking valve and they don't really know what's going on? What is their secretion management like? Perhaps the patient is tired, been pushed too hard today with rehabilitation and ventilator weaning, etc. So it's often, it's not the speaking valve itself, it's something that we've done wrong, or the timing hasn't been the best, etc. So just, a word of caution there about that. And the last myth is the patient was coughing lots with the one-way valve in situ. So I took it off and just let the cuff down. The patient is doing much better. So that's a quote from a bedside nurse. The patient was coughing. So I just took the valve off, but I left the cuff down, and look at the patient, they're doing so much better. Obviously, airflow via the upper airway enables sensation. We know that, and we saw that with that VF video just recently too. And full exhalation via the upper airway, which is what happens with the speaking valve, probably guarantees better sensation and definitely better glottic closure with improved subglottic pressures when compared to just cuff down. The patient coughing with the one-way valve in situ needs to be investigated by the speech pathologist, yes, but it is usually much more dangerous to leave them cuff down without the one-way valve in situ. And no cough does not mean the patient is doing better. It's actually likely the opposite in that case. And back to that slide, so laryngeal rehab, it should say, and order of laryngeal rehab with the goal to restore the upper airway function. We said earlier, in my world, and also my colleagues Sarah and Sue that we wrote this opinion piece with, starts with one-way valve that is most natural. If that doesn't work for some reason, we'd move on to above cuff vocalization. But also continue daily to assess suitability for one-way valve again. And if that doesn't work, then leak speech, if unable to do either of the above, due to either upper airway patency issues or equipment issues, meaning that perhaps the patient doesn't have a tracheostomy tube with above the cuff suction line. So very briefly about the other two options, ACV and leak speech. Obviously, you'd need the above the cuff suction port as mentioned, and you definitely need a patent airway, just like with a speaking valve or one-way valve use, the airway needs to be patent in order to avoid complications. And ACV, although not your natural full exhalation via their upper airway, but it also ensures some airflow via the patient's upper airway, enabling commencement with laryngeal rehab. And leak speech, whether it's with or without ventilator adjustments, full upper airway patency is not required because some air can also move back to the tracheostomy tube. Not all of it needs to move via the patient's upper airway. So if you have either partial cuff deflation or you have some upper airway edema that prevents all of the air from going up, then you just have less air going via the upper airway and more air coming back via the tracheostomy tube. So it's best used where potential for lung de-recruitment is not there or is not a concern. and the patient is for some reason not able to use a one-way valve for better coordination of respiration with phonation and swallow, and if ACV is not an option either. So there are definitely suitable candidates for leaf speech as well, but in a weaning patient on ICU, it's often hard to justify without having the research to back up what's actually happening to the patient's lungs. But it's definitely another great way to start laryngeal rehab if you can't do steps number 1 and 2 in our favored order. So in conclusion, I'd say start early. If upper airway is free from tubing, it's free for using. Restore the airflow to enable sensation and allow to work on motor response. So all of the swallow rehab that you do should also be happening whilst there's some airflow via the upper airway, just to ensure maximum input. Aim for closest to natural, so one-way valve, where all exhalation happens via upper airway. Definitely reassess frequently, and fees for any troubleshooting and rehab guidance, because this is what we want our patients to do. We want them upright, talking, eating even more, despite being on mechanical ventilation, just making sure that the respiratory and swallow coordination is abled as well. So like this patient here, I'll play for example.
What are you having, Eric?
Lemonade.
Lemonade. Great. Go ahead.
On the ventilator, having normal drinks, enjoying it, talking.
Is it good, Erin? Is it good? Yeah.
And then other patient, not eating or drinking this time, but just enjoying life. And with these two lovely chaps, finished with my slides. Thank you.